Hello, my name is Martha Lyon. I'm a clinical biochemist and I oversee point-of-care testing as well as pediatric and neonatal clinical biochemistry issues in our hospital. Today, I'm going to talk to you about the importance of accurate glucose meter measurements, in particular in critically ill patients. Before I begin, however, I would like to provide the following disclosures. I have received speaking honoraria from a variety of different companies, as I have listed on this slide. I have also received research support from a variety of different companies. And when I'm referring to research support, I specifically mean the provision of reagents, instrumentation, as well as travel. And then finally, I would like to acknowledge that I am the vice president of a very small clinical laboratory consulting company called Biomedical. I would like to start today's talk with a clinical case. This case involves a 54-year-old female. At presentation, this patient was not thinking clearly. She was confused, drowsy, which ultimately led to unconsciousness. The patient's glucose had been checked with a glucose meter, and the result was 187 milligram per deciliter. For folks in Canada, that translates into approximately a little over 10 millimole per liter. The patient's past history was that she was diabetic and she had a chronic kidney disease. The patient was taken to an emergency department at a nearby hospital. And when she was admitted to the hospital, the patient was unconscious. There was no response to deep pain. There was apparent flaccid paralysis in all four limbs. Her vital signs, however, were reasonably normal. Normal heart rate, blood pressure, as well as respiratory rate. At this time, the patient's glucose was also assessed with a glucose meter, and the result was reasonably consistent with the previous glucose meter measurement and was found to be 167 milligram per deciliter. The differential diagnosis for this patient had been brainstem CVA, metabolic encephalopathy, uremic encephalopathy, and a brain MRI had been ordered, and it was suggestive of a hypoglycemic encephalopathy. When the patient arrived at the emergency department at the hospital, the doctors had ordered laboratory investigations for which the results were received within an hour, about an hour later. And of note, the hematocrit and hemoglobin levels were low and the uric acid level was high. The lab result for plasma glucose was of most interest with this patient in that the result was 24 milligram per deciliter, which is dramatically different from the glucose results obtained from the glucose meters. The physicians responded to this very low plasma glucose result by administering 25% dextrose as well as a 10% glucose infusion. And within minutes, the patient regained consciousness and completely recovered from all of the neurologic deficit. This case concluded with the patient being discharged within 24 hours with the diagnosis of a hypoglycemic encephalopathy. The dramatic differences that we saw between the laboratory measurement of glucose and those achieved with the glucose meters could only be attributed to interferences with the glucose meters. Potential interference will include hematocrit, hemoglobin, as well as uric acid levels in the patient. Having warmed ourselves up to this topic with the clinical case, I would now like to present the objectives for my talk. The first objective will be to discuss the significance of point-of-care glucose testing in hospitalized patients. Secondly, I'd like to define the problems caused by glucose meter inaccuracy. And then finally, I would like to present clinical evidence to support the role of accurate point-of-care glucose testing in proper glycemic management. So how are glucose meters used in the hospital? Well, we know that glucose meters are primarily being used for the management of dysglycemia. And when we talk about dysglycemia, what we're meaning is we want to be able to detect hypoglycemia and we want to be able to detect hyperglycemia when it's occurring in our hospitals. When we look more closely where glucose meters are being used in the hospitals, we know that they're being used in the emergency department, on general medical floors, intensive care units, as well as in the nurseries. When we think about the emergency department, yes, they're going to be used for the assessment of diabetic ketoacidosis patients, for evaluation of unconscious patients, as well as assessment for hyper or hypoglycemia. Intensive care units will, depending upon if they're following tight or moderate glycemic protocols in that institution, will definitely be using glucose meters. In the nursery, well, they're using glucose meters primarily to be able to identify if a baby is at risk or is hypoglycemic. And when we think about the general medical floor, of course, it's going to be for the management of diabetic patients. Realizing that glucose meters are used widely throughout the hospital, and each setting where glucose meter is being used will have its own justification for using glucose meters. Ultimately, the end goal with glucose meter use wherever it's being used in the hospital is to enable glycemic control. So why are glucose meters so widely deployed throughout a hospital? Well, that's an easy question to answer because you can use multiple specimens with a glucose meter. You can have capillary, venous, or arterial specimens, and a glucose meter can handle those. It doesn't require a lot of blood. Also, it has a rapid analysis time. You can get your result with a glucose meter very quickly. Before I continue my talk, I would like to make a comment about a common practice of comparing capillary glucose and venous glucose results within the same patient. Literature exists that indicates capillary glucose can be up to 20 to 25% higher than venous glucose results. However, the literature does indicate that capillary glucose results and venous glucose results can be very close to one another, but only if a fasting specimen has been collected. As I've already mentioned, there are numerous advantages to using point-of-care devices for the management of glycemia, and all of these are beneficial when serial monitoring of a patient is required. When we think of any laboratory testing, we know that error can occur at any stage, including pre-analytical, analytical, and post-analytical. However, the pre-analytical phase tends to be where most of the error is associated, and the evidence indicates that up to 68% of laboratory-associated errors occur in the pre-analytical phase. Glucose meters are not different. The slide shows the various broad groupings of sources of errors and interferences associated with glucose meters. And these errors range from user errors resulting from inappropriate sampling technique to exogenous factors like acetaminophen interfering with the performance of a glucose meter. The reason I've included this slide is because I really want to emphasize that analytical interference can lead to errors in glucose results, which in turn could lead to inappropriate or potentially harmful clinical treatment to the patient. And I think the intriguing question is that associated with all of this is what error is acceptable between a glucose meter and the laboratory glucose method. This slide illustrates two case studies that report the effect of galactose to interfere with glucose meter performance. In the first case, the neonate had prolonged jaundice, liver dysfunction, and renal tubular disease. The glucose meter reported a glucose of greater than 15 millimole per liter, which is greater than 270 milligram per deciliter. The baby had been treated with insulin, but the baby's condition continued to deteriorate. Throughout this case, the laboratory plasma glucoses were reported they were consistently low, and the baby was ultimately diagnosed with galactosemia. The second case that I have on this slide really just re-emphasizes the first case in that it also does show the effect of galactose and how galactose can interfere with certain glucose meters. And it's important to be able to distinguish glucose from a galactose, in particular in the neonatal population. When we look at the structure of glucose and galactose, you can see that they are remarkably similar, except for the position of the hydroxyl group that I have outlined in red on this slide. I would like to emphasize the importance of being able to distinguish a glucose from a galactose in context with identifying neonatal hypoglycemia. As we know, there are numerous glucose concentrations that have been reported in the literature as to alert or action values that require clinical intervention. These range from 1.6 millimole per liter, which is 29 milligram per deciliter, 2 millimole or 36 milligram per deciliter, 40 milligram per deciliter, 47 milligram per deciliter, or 49 milligrams per deciliter. All of these concentrations have been listed in various clinical practice guidelines as potential action or alert values in the neonatal population. Several years ago, we investigated the potential effect of low concentrations of glucose that are consistent with the alert or action values that I've just mentioned, and low concentrations of galactose. We deliberately looked at low concentrations of galactose and not the high concentrations that are associated with patients diagnosed with galactosemia. Now, this figure and table show that with the particular glucose meter that we were using, that even low concentrations of galactose could interfere with the meter's ability to measure glucose, and it was resulting in a positive bias. So the results were artificially elevated. The results that I'm showing in this slide are glucose in units of millimole per liter. This slide shows the same data with the same glucose meter but the glucose data are represented in milligram per deciliter. The concern I have with the performance of this glucose meter is that it would inappropriately indicate higher glucose values than the baby actually has, and this could result in the potential failure to identify an actual hypoglycemic event. This slide shows the results of the same study design, but with a different glucose meter. And as you can see in this case, the glucose meter was absolutely unaffected with combinations of low glucose and galactose. And these are the same results, but the glucose values are expressed in milligram per deciliter and not millimole per liter for the second glucose meter. And you can see that the second glucose meter was absolutely unaffected by galactose interference. This slide shows the structure of several non-glucose sugars, including galactose and lactose, that have also been reported to cause analytical interference with glucose meters. I would now like to present a case report of an icodextran interference with a glucose meter. This case was published in 2013 in the journal A&A Practice. It involves a 65-year-old female. Her history is end-stage renal disease secondary to hypertensive neuropathy, and she was admitted for renal transplantation. Past history, coronary artery disease, chronic anemia secondary to renal disease. She was on continuous ambulatory peritoneal dialysis and had no history of diabetes mellitus. On the day of surgery, the patient was awake, alert, neurologically intact. And after the surgery, the patient arrived in the care unit, the post-anesthesia care unit. She was receiving pain management, and a finger stick poke was done. And the glucose came back at 340 milligram per deciliter. As a consequence of this, the patient received continuous IV insulin infusions and was discharged to the floor and considered in stable condition. On her first post-operative day, the patient in the morning was awake and alert. However, in the afternoon, the patient became increasingly sleepy, and it was decided to transfer the patient back to ICU, and hemodialysis was initiated. By 1900 hours that night, the patient was unresponsive to painful stimuli, and the patient was intubated. On the second postoperative day, an MRI and ECG had been ordered, and the results were consistent with a toxic metabolite encephalopathy. Interestingly, during that day as well, the laboratory glucose result came in at 43 milligram per deciliter, and this was dramatically different from the previous results obtained with glucose meters, which were in the very high 300 milligram per deciliter range. The physicians responded to this low glucose from the laboratory. The insulin infusion was discontinued, and a dextrose solution was immediately administered IV. This table outlines the discrepant results for glucose measurement between the point-of-care glucose meter and those obtained with the laboratory. The glucose results obtained with the glucose meter in this particular case, were used to titrate the insulin infusion for the patient. And it was calculated that the patient had received up to, very close to, 116 units of insulin before the discrepancy had been identified between the glucose meter and the laboratory. The outcome of this case was that the patient never recovered neurologic function. There had been prolonged hospital stay because of the discrepant results and the treatment that the patient had received. And the patient was never able to be discharged back home and had to be discharged to a care facility. By presenting these case reports, I wanted to demonstrate that interferences in glucose measurements can lead to inaccurate results, which in turn have the possibility of causing inappropriate treatment for the patient. And in some cases, these errors can actually represent a hazard to the patient. This figure was taken from a paper published by Thorpe in Diabetes Technology and Therapeutics in 2013. And what it indicates are the number of publications that were assessing the performance of glucose meters between 2004 and 2011. And what can be seen is that in the early 2000s and prior to that, there were not a lot of publications regarding glucose meter performance. But since 2009, since 2010 and onward, as a community, we are becoming more aware of the performance or issues with the performance of glucose meters. For the remainder of my talk, I will be focusing on the use of glucose meters with critically ill patients. I would like to focus on how did we get to where we are today. Critically ill patients can be found in many different locations, from the ORs to NICUs, nurseries, emergency departments, and oncology and dialysis units within our hospitals. As I previously mentioned, it was in the late 1990s and early 2000s that healthcare professionals started to become much more aware of the performance of glucose meters and how this performance could influence the quality of care for intensive care patients. For example, in 2001, Vandenberg reported that tight glycemic control could reduce morbidity and mortality in critically ill patients. Tang and Louie in 1999 and Dungan in 2007 reported interferences with glucose meters. In 2009, the outcome of the NICE sugar trial resulted in many questions about glucose meter inaccuracy and the clinical risks that could be or might be associated with using these inaccurate meters. To present this in a timeline, there were controversies regarding the analytical accuracy associated with glucose meters and the use of tight glycemic protocols for critically ill patients. The FDA responded to these concerns and held a public forum in March 2010 where the use of glucose meters in critical care settings had been discussed. Later in 2010, after this FDA public forum, the FDA required manufacturers of newly cleared meters to add a limitation, and that limitation was that the meters were not for use in critically ill patients, and so the manufacturers had to have this included in their product label. However, a little bit later in 2010, in November of 2010, the FDA actually modified that limitation statement to say that the product label should say not evaluated in critically ill patients. It was shortly after this FDA meeting that other organizations like ISO, CLSI, as well as NACB, they modified their performance expectations for glucose meters. In September 2014, the FDA approved the first glucose meter for use in critically ill patients, and that was the Nova StatStrip glucose meter. At this time, the FDA approved the following specimen types for use with the Nova StatStrip glucose meter, and those specimen types were venous, arterial, neonatal arterial, and neonatal heel stick whole blood samples. Capillary use and the collection of capillary samples has not been approved. In October of 2016, the FDA published new guidelines for the verification and validation of the performance of glucose meters, and what was interesting was that they had different and distinctive performance expectations for hospital-based glucose meters as well as glucose meters for home use, the self-monitoring glucose meters. This slide shows the performance expectations proposed by the FDA for the home use glucose meters as well as the hospital glucose meters. And you can see the differences in the performance expectations that are proposed by the FDA for each of these groups of glucose meters. With the next series of slides, I will be describing the international multi-center clinical trial that was conducted by NOVA that enabled clearance, the FDA clearance for use in critically ill patients. The results of this multi-center trial have been published in Critical Care Medicine, actually this past year, and I will now like to describe in a little more depth the various aspects of the study. This trial was conducted at 5 university hospital medical centers, for which 3 were in the United States and 2 in Europe. 1,698 critically ill patients were enrolled, and this resulted in 1,815 glucose measurements. 257 different specific critical care conditions, including the severity of illness scores, were noted with these patients, as well as 134 different drug subclasses were also noted within these patients. In this study, the analytical performance of the glucose meter was compared with the IDMS-aligned central laboratory glucose methods. In addition to this, the clinical risk associated with the use of this glucose meter in the critically ill population was assessed using the POCT error grid as well as the Monte Carlo simulation studies. Glucose meter performance expectations outlined by CLSI POCT 12A3 were also assessed in this trial. Stratified sensitivity and specificity analysis was also conducted, as well as the performance of the glucose meter in the hypoglycemic range was also assessed. In this figure, the ICU patient correlations between the glucose meter and the central laboratory methods is depicted on the POCT error grid. The POCT error grid was developed in 1994 based on a survey of 100 expert physicians who treated diabetic patients. The POCT error grid it identifies 5 zones, A through E, based on the extent of analytical differences between the 2 glucose methods being tested. Glucose results in the A and B zones are associated with the least clinical risk, whereas results in zones C, D, and E represent increasing clinical consequences. 99.3% of the ICU patient results in the trial were located in Zone A of the POCT error grid, and 0.7% of the results were located in Zone B. When the performance of the glucose meter was assessed according to the CLSI POCT 12A3 criteria, it was found that 95.4% of the results that were less than 100 milligram per deciliter, which translates into less than 5.5 millimole per liter, that 95.4% of those results fell within the required plus or minus 12 milligram per deciliter criteria. For results that were greater than 100 milligram per deciliter, 96.5% of the results fell within the required 12.5% of the laboratory glucose results. Sensitivity and specificity was determined at the various glucose concentration intervals outlined on this slide. The overall sensitivity of the glucose meter was calculated to be 95.2%, and the specificity was determined to be 95.8%. In order to assess the clinical risk of using this glucose meter in a critically ill population, Monte Carlo simulation modeling was performed. And the next series of slides will be used to describe what the simulation model tested. Monte Carlo simulation is a mathematical technique that we use to assess the clinical accuracy of the NOVA glucose meter. In 2001, Boyd and Bruns demonstrated the theoretical utility of using this simulation model to estimate the effect of glucose meter bias and imprecision with the clinical risk of inappropriately administering insulin. In 2010, Brad Karen and his colleagues used simulation modeling to understand glucose meter performance with potential insulin dosing errors during tight glycemic control. And this study was published in 2010 in Clinical Chemistry. This figure is a frequency distribution graph from the Karen publication. And it demonstrates or shows the glucose results obtained for 6 months. The corresponding insulin dose in units per hour for each glucose target zone is also shown on this graph. In the Karen study, they wanted to assess the relationship between glucose meter accuracy and insulin dosing error. Specifically, the effect of combinations of glucose meter bias and imprecision were examined. How this works is that essentially the first step that's being done by the computer is the computer randomly accesses a glucose result from the 29,000 plus glucose results from the frequency distribution data. And in this case, let's say it was a result of 182 milligram per deciliter. The computer program will then add 1% imprecision and all of the combinations of 1% imprecision with biases from 1% to 20%. After the calculations are completed for the 1% imprecision, the program will continue to calculate all the combinations of imprecision and bias up to 20% for each bias and imprecision. This subsequently will result in 400 error estimates for each initial glucose value assessed. Since bias can be both positive and negative, this will result in two new results, glucose results, for each bias and imprecision combination being evaluated. The insulin dosing categories for each of these newly calculated results was then determined, and it was represented with the following contour plots. This slide shows the contour plots indicating the probability of greater than 1, greater than 2, and greater than 3 dose errors in insulin dosage in relation to meter bias and imprecision. Meter imprecision is plotted on the x-axis, and meter bias is plotted on the y-axis. The Karen study concluded that the current glucose meter performance expectations at that time in 2010, they were 20% total allowable error, and Brett's study concluded that this may not be optimal for patient management during tight glycemic control. And Brett's study also concluded that 1 and 2 dose insulin errors were actually very common. In our trial with the Nova glucose meter, we found a very low probability of administering greater than 2 or greater than 3 doses of insulin. The probability was determined to be 2.3% and 1.8% for 2 and 3 category errors, respectively. With respect to the performance of the glucose meter in the hypoglycemic range, a 99.1% concordance with the central laboratory methods was noted. Overall, the clinical accuracy assessment algorithm that I've just described is an effective tool to comprehensively assess the analytic performance and clinical risk of using a glucose meter in the critically ill population. To conclude my talk, I would like to briefly address the question, what are the clinical benefits of an accurate point-of-care glucose result? I like answering this question in context and putting it in context with a pyramid. If we have a meter that is as accurate as possible, then it will assist with the appropriate identification of hypo and hyperglycemic events in our patient populations, which in turn should improve clinical outcomes because the potential of treating results obtained due to interferences with the glucose meter will definitely be less. These are examples of what I mean when I say improved clinical outcomes, and there are numerous improved clinical outcomes. Literature has been published that indicates a reduction in hypoglycemic events and glycemic variability, to reduction in insulin dosing errors and the quantity of insulin administered, as I've already presented earlier in this talk. In a 2014 presentation from Dr. Sharita Golden from Johns Hopkins, she presented results of a before and after implementation of a hospital glycemic management program. And she reported a 36% reduction in in-hospital mortality, a 2.7-day lower length of stay per admission, and a $3,900 decrease in hospital costs per admission. In 2016, a team from the divisions of clinical biochemistry and neonatology evaluated the NovaStat strip glucose meter for use in the NICU at Toronto Sick Kids Hospital. Specifically, they wanted to assess the impact of implementing this meter on clinical outcomes in their NICU. And what they observed was an increased sensitivity for the detection of hypoglycemia, a much lower false negative rate, and an improved ability to be able to rule out neonates who are not at risk for hypoglycemia. They observed a threefold reduction in false positive glucose measurements. They observed an improvement in identifying neonates who were at risk for hyperglycemia. They observed lower mortality rates, and they also observed less endocrine consults. The last study I would like to present is work done by Dr. Nam Tran and his colleagues at UC Davis. In this study, Nam and his colleagues assessed the clinical impact of implementing an accurate glucose meter for monitoring a tight glycemic control in severely burned children. The outcomes that they reported from their investigation were fewer hypoglycemic events, significantly lower median glucose concentrations, and significant lower glycemic variability. But they also identified that there was an increased percentage of patients' values that were being maintained in the target range for their tight glycemic control protocols. To conclude my talk, I'd just like to say that glucose results are definitely a key component in the management of a patient's glycemic state. We know that glucose meters are frequently used in high acuity settings, that patient-specific interferences are actually more common in high acuity settings, and that these interferences can definitely affect the accuracy of glucose meters. Accurate glucose results are definitely essential for proper management of a patient's dysglycemia. Thank you very much for your time and attention. Good afternoon. It's Martha Lyon. I'd like to thank everyone for sticking to the bitter end of my talk and listening to it. And I'm actually calling in on the phone, so I'll try to see if I can answer any questions that you may have. I believe at the beginning of the presentation, or at least I hope you were informed of this, that there's the question and answer box, and if you have any questions, please type them in, and what I'll do is I'm going to click on them, and then I will try to give an answer to it. So I'll start with the first question.
And the first question is there a glucose meter FDA approved for testing the critically ill using a capillary sample? And the answer to that is, to my knowledge, no. No glucose meter has been approved yet. And actually, tomorrow and the next day, the FDA, Thursday and Friday of this week, the FDA are going to be hosting meetings in Washington to be able to discuss what criteria and what do we have, what should we be thinking about, what amount of error can we consider acceptable with a capillary sample and glucose meter measurement. I hope that answers that first question. Next question is, what defines a critically ill patient? That is an excellent question. And I have to say, I haven't found a definition of a critically ill patient. And I believe that in many documents, they say that we have to be careful, obviously, about the application of glucose meters with critically ill patients, and they leave it up to the discretion of the medical director to describe or define a critically ill patient. And I'm not sure that anyone has come out and provided a definitive definition of a critically ill patient. Now, if anybody does know a definitive definition, then I would say, please, with this question and answer, please comment, and then I will read your definition. But to my knowledge, there isn't a universally accepted definition of critically ill patients. So sorry, I can't answer that one. Next question. I like this question too. Is a neonatal heel stick whole blood sample different than a capillary sample? And fantastic question. I have to tell you that when I've given this talk live, I've always commented on that because to me it's the same thing. And so I do not understand the language behind defining it as a neonatal heel stick whole blood sample, because to me, I agree with you. That is definitely a capillary sample. Next question. How can staff easily determine if a patient is critically ill? I'm going to have to defer that question in that it goes back to the definition of critically ill patients. And I know we've got different units that we have in our hospitals where we will have patients admitted to those units who are higher acuity patients. And so those patients I think it goes to say that those patients will require more medical attention and more medical intervention potentially. But to be able to say, how do we know for sure? How can we easily determine or define a critically ill patient? I'm so sorry, I can't define it. Next question. What specimen type is suggested for use and testing in critically ill patients? That is... Again, that's a source of a delicious controversy in that there are people and groups, hospital systems that do not want to use open up lines if they're indwelling lines for the patients, because by accessing those lines, people are concerned that could increase risk of infection, contamination, etc. And the other group of folks have mentioned that it should be fine using a capillary specimen in critically ill patients. Both of these, when we have a critically ill patient, commonly these are the patients who have hypoperfusion. And when you think about the use of a capillary specimen, you definitely want to be able to know that the specimen you're collecting is going to be optimal. And so it really is, again, I can't say that one specimen type is preferred over another. You're definitely going to find papers that will say a venous specimen or arterial specimen is better than a capillary specimen. And right now, at least in the U.S., no glucose meter has been approved for capillary use yet. So I think you do only have the choice of an arterial or a venous with in the intensive care areas. Next question. Oh, excellent. And this is from Baptist Hospital. I can't see Baptist Hospital Paducah, where they said our facility has defined critically ill as a patient who is actively coding 30 minutes past the code or has a low blood volume with a hematocrit of 10% or less. Thank you very much. If any other folks have definitions of critically ill, please feel free to type in and I'll read them for people. Next question is it best practice to correlate a point-of-care capillary sample with a lab blood sugar value to treat hypo or hyperglycemia in a critical care setting? I know, and it's interesting because I wanted to include a couple of slides in this talk to be able to talk about correlations or comparisons between capillary glucoses and venous glucoses. I'm a pediatric and neonatal clinical biochemist, and so I know in the various hospitals that I've worked in, it's been common practice in our NICUs where the babies would have the heel poke being done, which, in my opinion, that is a capillary specimen that is being collected. And then should that capillary result, that glucose result, get to a critical low action level, then it's common practice that that specimen, that baby's venous blood would be collected and then sent to the laboratory for confirmation. But it's actually really interesting because, and I went back to look, and there were 3 references. The first reference was in 1976, another reference in 1983, and another one in 2001. And what they've indicated that you will not see any differences in capillary and venous glucose if the patient has been fasting. So, but after a glucose load, the levels are going to be consistently higher in a capillary specimen rather than that venous specimen. So it's and the question that was asked was, is it best practice to correlate a capillary with a lab sugar? And the answer is yes, you can do it, but what I would recommend is that you have to compare apples to apples. So please, if you're collecting a capillary specimen, send a capillary specimen to your laboratory if they are able to conduct that analysis there. Or collect a capillary and run it on your blood gas analyzer. So please try not to mix and match unless you know exactly the fasting situation with the patient. I hope that's answered that question. Next one, can you repeat the definition, please? Yes, I definitely can do that. And this is from the Baptist Health in Paducah. And Their definition is, our facility has defined critically ill as a patient who is actively coding 30 minutes past the code or has a low blood volume with a hematocrit of 10% or less. So that is the definition that was provided by Baptist Health Paducah. Next, moving on, we have, okay, here's another individual, the Adventist Health, and I'm sorry, I've only seen a portion of this. They say, we have defined critically ill as a patient that has a capillary refill time of greater than 3 seconds. So that's another definition. And another question is, will your presentation be available for us to review later? I'd like to share it with others on my team. I'm not sure. I believe if you contact NOVA, they would be able to discuss that. I'm sorry, I can't answer that. Next one here is another definition. Fantastic. I love these definitions. Medical center defines critically ill patients as those who are located in the ED, cath lab, OR, PACU, ICU, NICU, or PICU, and meet one or more of the following: mechanically ventilated FiO2 and GT 60%, invasive hemodynamic monitoring, arterial PA catheter, CVC monitoring, and on pressors, active titration of IV vasoactive medication above minimal amounts. This is a very detailed definition, which is great. Cardiac assist device such as IABD, Impella, and ultrafiltration or CRRT in progress. So that is a fantastic definition, and thanks very much, folks, for providing definitions. Suggestion, this one is, Okay, so this was a suggestion by an individual saying that, well, I've been waiting for a definition. I've been training end users using the language that if you have a patient with poor peripheral perfusion, a capillary specimen is not your best choice. Example, just trying to get this here. Example of a patient in shock or on vasopressors. The definition of critically ill our organization is leaning towards is a patient on vasopressor or in shock. So I have been proactively getting my end users to start thinking that way. Another individual, nope, didn't get that one. We'll move on. Definition for ARF is defined as, let's see if I can find that. Nope. Just moving on to the next one. Another definition. So I've had several definitions for people with how to define critically ill. And so what I'm thinking we might do is, with the NOVA representation and help, how about what we'll do is we will take people's different definitions and summarize them for you, and then make that available to you so you can see where the various, the different companies and organizations, as well as the various definitions that they are using. And someone just asked if I would post all the definitions, and yes, I think that is makes a lot of sense. Next question is, since the hematocrit of a neonate is high, and typically blood gas analyzers have hematocrit interference at high levels, do you recommend using a blood gas analyzer in a neonate population? I have seen a high bias in a blood gas analyzer as compared to the Nova glucose in a neonate population. So do I recommend it? Yes, and actually that's the source of a different conversation or another conversation, because with a blood gas analyzer, you're looking and measuring sort of a pseudo-molality measurement as opposed to the molarity measurement. And that is commonly detected with many glucose meters. So the hematocrit interference that you have experienced with that blood gas analyzer using that neonatal specimen, that may have been specific for a particular blood gas analyzer. I know I've assessed several different blood gas analyzers, and I can say that not all blood gas analyzers are created equally. Let's see. And I think the last question I have is, I'm sorry, that wasn't the question. So, are there any other questions? Oh, another question. Okay, so I've just received another example of a definition. So we'll definitely summarize the definitions and try to get those out to people. Right. Okay, the question that just came in is, to my knowledge, it's recommended to repeat critical point-of-care glucose produced from a glucose meter. First, again, with a glucose meter, and then confirmed with a lab draw. What is your recommendation? And I agree with that recommendation. My only proviso with that is, though, be careful that you are not mixing and matching a capillary specimen with a venous specimen, because, and in particular with neonates, not knowing or because of how frequently the babies are feeding, and knowing the effect of that glucose load on causing differences between the capillary and venous results. Next one, if you click on that. Oh, someone has just said that if you click on the green resources at the top of the screen, you can click on the slides and save to your computer. So if you'd like to do that, do feel free. That was just a comment. So to say, if you click on the green resources at the top of your screen, you can click on the slides and save to your computer. So I would like to thank, if there are no other questions, I'd like to thank everyone for your questions. Those were wonderful questions. We will summarize. I'll ask Nova if they could summarize the definitions and send those out. I think that was great. And thank you so much for your time and attention. And enjoy the rest of your day. Bye.